I've been asked to give this talk about cash transfers and TB elimination, and I've been provided with a very ambitious questions about whether or not cash transfers really work or not. And I think that the most honest answer to this question is that I have no clue at the moment. I think I know something. I think we can say that we know a bit, but definitely there's still a lot to do. Despite the fact that we still don't have that many answers to this question, I think that the question can be still potentially quite relevant for our discussion today, and I think potentially very relevant to inform and to shape the future of TB elimination. I will use the next 25 minutes, more or less, to argue that in fact there is a strong intersection and alignment between TB elimination and the Sustainable Development Goals. And I will do that by showing how these two entities overlap in terms of targets, in terms of strategy that they propose, in terms of the rationale, the scientific underlying rationale that support this alignment. After providing some kind of basic definition about what social protection is and what cash transfer really are, I will provide you with an overview about the available evidence about the impact on cash transfers on a number of TB indicators, and I will provide you also with an overview about the huge operational challenges ahead that we have when we think about integrating existing TB control activities with social protection actions. I will there illustrate how rich, however, is the research landscape ahead, our research portfolio, to try to understand better the question. And I will conclude by giving you an idea about what is the research roadmap that we have. So let's start by positioning ourselves within the context of the Sustainable Development Goals. You are probably very familiar with this picture, and you know that TB is under goal number 3, and specifically goal number 3.3, which says that by 2030 the epidemic of AIDS, tuberculosis and malaria should end, and other neglected tropical disease, which translated in numerical target means to achieve respectively the 80% and 9% reduction in TB mortality and TB incidence. These targets are very consistent with the targets that have been proposed in the new TB elimination strategies for the year 2030. But the TB elimination strategy goes a bit further and gives also even more ambitious targets for 2030 and 35. Clearly, they're very optimistic about what they can do in just 5 years from 2030 to 2035, and propose a goal of a 95% and 90% reduction, respectively, for mortality, TB mortality, and TB incidence. And of course, a key element of these targets is also the elimination of catastrophic costs faced by affected TB-affected households and individuals. The intersection between TB elimination and Sustainable Development Goal is also in terms of strategies. In the target number 1, in the objective number 1, the SDGs propose also the roll out and increase the coverage of social protection in order to reduce extreme poverty, to alleviate poverty among the most vulnerable groups. And this is also a key element of the TB elimination strategies, which for the first time include social protection and poverty alleviation among the key actions and bold policies to implement in order to tackle the social determinants of TB and enhance TB elimination by 2035. But what is it, social protection? In case you're not familiar with this concept, social protection is indeed a very broad container, and there is still no clear consensus about what should really fit into this broad bucket. And a number of definitions have been provided, but for us, a good working definition is the one provided by De Verhoek, according to whom the social protection is a number of initiatives including social assistance, social services, social insurance, and social equity that are provided to people living in extreme poverty in order to move them out of extreme poverty and protect them from catastrophic and future shocks. This lies also as a sort of taxonomy of social protection. Social protection is part of the social services provided by a governmental welfare program, together with health and education. Within social protection, there are at least 3 streams of actions that can be taken, which include social legislation to protect the citizens' rights, which are basically human rights. There are social insurance that are basically pension schemes or disability type of grants. And then there are social transfers that are including the cash transfer that we are talking about today. Social transfer falls within the remit of the social assistance dimension of social protection. And as I said again, it's a way to provide people with cash or food or other in kind in order to remove them, to move them away from extreme poverty. Social transfers and cash transfers are predictable because they are given to people regularly at a specific deadline every month, can be given unconditionally or can be given conditionally upon a number of requirements and behaviors like sending kids to school or having access to the healthcare systems and having the kids vaccinated or checked up. They're not used as a sort of strategy in a situation of crisis. They are given to vulnerable people to make them more secure. And the kind of money that the people are given can be saved or can be reinvested or can be used sometimes also to simply comply the conditionalities that we have requested. To be completely honest, the concept of social protection is not entirely new and is definitely not new in the field of TB. Even Robert Koch, which is not strictly exactly a fanatical of poverty alleviation, in 1905 in his lecture for the Nobel Prize Award, indicated and social welfare centers as a key element of the fight against the disease. And he said, a sick person is visited in his home and is given instruction and advice concerning cleanliness. If living conditions are bad, then money is granted. So this is Robert Koch, more than 100 years ago. The third dimension of intersection between TB elimination and SDGs is also conceptual and scientific. We know that TB elimination is good for development. At macro level, there are a number of evidence that suggest that elimination of TB would definitely improve economic growth and development worldwide. According to the World Bank, for every 10% increase of TB incidence, there is a loss of about 0.2 and 0.5% in economic growth, something that translates into an annual loss of about $3 billion, probably due to the loss of productivity. A recent study from Stéphane Verguet on Lancet in 2015, I think, showed that in Ethiopia, TB treatment was proven to be one of the top interventions, not only to reduce mortality, but also to avert poverty, with about 96 cases of poverty that could be averted for every $100,000 spent on TB treatment. And in a less kind of scientific type of way, The Economist put TB among the top interventions, the best investment in order to achieve development. At micro level, the impact of TB on human capital and development are no less dramatic. We know, and it's quite well acknowledged, that TB affected households and individuals often face catastrophic costs that can reach more than 20% of their annual household income. We know that the burden is even higher among the poorest households, and we know that despite the fact that we know exactly the extent of impoverishment that is caused by this catastrophic cost, in other words, we don't know whether these people enter chronic poverty or go chronically below the poverty line as a result of catastrophic cost. We know for sure that these households are forced to take quite drastic compensating and coping mechanisms in order to adjust for these shocks. More recently in Peru, another study showed that the implications of catastrophic costs are not just financial, but also clinical, and they have proven, they have demonstrated that there is an impact also on TB mortality, TB treatment abandonment, and TB recurrence. And I'm sure that all you guys, you all know that without development there is no TB elimination. You know the adagio in North America and in Europe, TB was in widespread decline before the introduction of any systematic biomedical intervention. I start to be sick of repeating the same story over and over again. You know that there are mountains of evidence on the ecological association between poverty and TB. You know that a number of studies have also shown that even today, the main driver of TB elimination are not strictly DOTs and biomedical interventions, but seems to be still development indicators. And I'm sure that you know this graph that shows that for sure the game changers in the fight against TB will be the development of new biomedical tools, including a new vaccine, better diagnostics, better, more effective treatment. But we also know that these products will probably will be developed in about 10, 15 years. Maybe Helen will give us more encouraging news, but I don't think there is any sign that things will change before than that. But there is an opportunity to still impact TB incidence decline by simply combining existing biomedical activities with social protection intervention. But how social protection and specifically cash transfer can act? So consistently with what we know for HIV and AIDS, we have conceptualized this effect into an impact into TB prevention, TB treatment, and TB support, whereby TB support I mean mitigation of catastrophic cost. We can assume that social protection strategies based on food and cash transfer can have an impact on these TB outcomes, either indirectly by acting on these distal factors, including socioeconomic position, education, food security, or directly if we assume to impose some conditionalities that are related to TB, like, for example, completing their treatment or completing chemoprophylaxis. We can assume that these distal factors can have an impact on more proximal risk factors, including the ones that I've listed here, including environmental and community characteristics and biological risk factors. And these proximal risk factors may have by acting on these proximal risk factors, we can detect an effect on prevention, treatment, and support, depending on which stage of the disease is affected, which ultimately is influenced by the type of people that we target with these interventions, whether people that haven't yet developed TB or people that have already developed TB. As you can see, there are 3 levels of impact: a distal level, more proximal, and actual TB indicators, which correspond to 3 different extent of knowledge that we have today. As for what concerns distal factors, there is strong and consistent evidence that cash transfer have an impact on poverty reduction, have an impact on the reduction of inequalities. And there is a growing body of positive evidence that cash transfers have an impact on education and food security and food consumption. When it comes to the impact on the intermediate, more proximal level factors, there is a strong logic, but is where the evidence becomes a bit more weak and mixed and inconsistent. And when it comes to the third level, the direct impact on actual TB indicators, there are very limited evidence to date, but the results are somehow encouraging. I'm going to show you an overview of the most recent evidence that we have, and I have deliberately concentrated on studies that have focused on either interventions that have been delivered within the National TB Control Program or within a broader governmental welfare schemes, or studies that explicitly mention cash transfers interventions. And I've left out the vast literature about the use of incentives and enablers. This because this literature is quite heterogeneous, very difficult to interpret, and I'm not entirely sure that is exactly the same stuff we're dealing with when we talk about cash transfers. So this table, which is quite dense, show the kind of the best that we know about the impact of cash transfers on TB indicators. As you can see, the oldest paper dates back to 2013, so it's a very young field of work. There is an over-representation of Latin America with Ecuador, Peru, and Brazil, with the exception of 2 studies in South Africa and Peru that use a randomized control trial. The other studies are just observational studies. The TB outcomes investigated are mainly TB treatment success, the default among MDR-TB patients in Ecuador, and in the case of Peru, the uptake of preventive therapy, TB cure rate again, and catastrophic cost mitigation. All this, with the exception of the study in South Africa, where they could find a positive association between the use of cash transfers and an improvement of TB treatment success, but that wasn't significant. For all the other studies, including the one that is part of the special issue of the transaction journal, there is a consistent positive effect of cash transfers on these TB outcomes. And the situation is more or less the same, is somehow supported by 3 recent ecological studies that shows that TB incidence and prevalence and mortality are constantly declining if we improve social protection spending and coverage. Despite this evidence are encouraging, and I'm myself impressed about how much progress we have done with the resources that we have, there's still too little to address properly the original questions. There are too little. There's an enormous variability among studies in terms of design and implementation. We might have some positive evidence about the effect of these interventions, but we don't understand why they work. So there's still a lot to do in order to understand what is the relationship between the results that we have observed and what has happened during the intervention, and what kind of elements have driven the success of the intervention. There is an uncertain learning opportunity from these studies because, as I said, for example, Sub-Saharan Africa are very poorly represented, so I'm not sure we can really guarantee transferability. Most of these studies refer to studies that interventions that have been targeted to TB-affected households or individuals with the precise intent to improve TB indicators, which in social protection terminology refers to TB-specific interventions, while the challenge and the ultimate goal for people like us working on the intersection between development and public health is to move towards TB-sensitive intervention, that is, existing social protection cash transfer schemes that can become more inclusive and allow more and more TB patients to be eligible for them without picking them up because they have TB. And this is the only way to ensure equity, reduce stigmatization, but also ensure sustainability. However, the shift from TB-specific to TB-sensitive to a more inclusive social protection towards TB brings a lot of operational challenges. First of all, there is an inverse care law pattern by which countries that could potentially most benefit from a better collaboration between social protection and TB control programs are also countries that have a very fragile social protection environment. There is an issue about targeting. Of course, as I said, we need to move towards a more sensitive approach by which we don't target specifically TB patients. But TB is a relatively rare disease. If we want to detect an impact, we might risk to dilute too much the effect if we just address the general population. We don't know whether we can afford to have conditionalities, both in terms of monitoring them and the financial consequences of them, but also in terms of the ethical aspect of that. Can we impose conditionality on TB if, for example, the TB services in a specific environment are not that good? Can we ask people to still access them even if they're not good enough? And of course, there are enormous ethical issues about whether or not we should pay people to obtain public health improvement, whether we should be careful in not incentivize pervert behaviors that might, under the assumption that if you stay sick, you are eligible to get money. And of course, there is the financial sustainability of these schemes, that most of these schemes have already a very stretched budget, and it's unclear whether we can go to the Ministry of Development in the most fragile countries and say, can we not include TB in your list of objectives, because it might be not their priority. we are trying to do our best to try to fill all this knowledge gap, and this very chaotic slide shows the kind of projects that we have in our pipeline. Even people not working on diagnostics have a pipeline. And these bubbles represent the projects that I'm aware of, projects that are currently ongoing or that are about to start. They haven't been ranked in a specific order. The size of the bubble doesn't reflect the importance or the size of the project. The only coding that has been applied is the color one, where the red ones are more methodological projects that are aimed to improve or produce methodological advances in our way to evaluate the impact of cash transfer on TB. And the most recent one is this S-Protect project that has been recently founded at the school and that has been founded for the creation of a multidisciplinary modeling consortium to develop a model that can encompass the complexity of social protection and socioeconomic drivers of TB within existing models. Then the kind of pinkish bubbles represent projects that are more about how to translate or support countries in the implementation of social protection, and the rest of the bubbles are about projects that are aiming to produce and generate evidence about the impact of cash transfers. And 4 of these projects are based in Brazil, which is, despite Zika and despite the financial crisis, despite Lula's being arrested, despite everything else, seems to be pretty engaged in the discussion about the use of poverty alleviation to fight TB. Now, what is the challenge? The challenge is to try to tie up the scene and to organize this project within the same kind of scientific framework in order to share lessons and knowledge, improve comparability, and optimize impact. And this is what we are trying to do with SPARKS, which is the first research network about social protection and health, which is a network that has been created by people from the London School and people at the Karolinska Institute. There are 3 streams of work under that sustain this network. There is a methodological one, an impact and operational evidence generation one, and the 3rd pillar is about result dissemination and policy translation. Consistent with these 3 streams of work, the SPARKS has the 3 research objectives that is mainly to develop new methodologies to understand better the impact of social protection and cash transfers on TB, generate rigorous impact and operational evidence, and synthesize and disseminate evidence in a way that countries can adopt and take the policy requirements. The idea is to populate this network with this first round of project, produce lessons and knowledge in order to inform a second round of project, possibly better and even more ambitious. So in conclusion, do cash transfer really work for TB elimination? So I don't think I have an answer. I wish I had, but I don't have. But I know that we can no longer afford to not to know. I think that we are applying here a kind of double standards when it comes to social protection and cash transfer for TB. And by that I mean that, yes, we know that the evidence that we have are very limited, which might justify no action for the use of cash transfer. But if we are here to adopt a strictly evidence-based agenda, then why the mountains of evidence about the importance of social determinants are systematically ignored? Why the evidence that shows that our biomedical approach alone is not likely to succeed in TB elimination doesn't change our behaviors and our direction? So if you can tell me, where is the logic of that? Cash transfers are just one entry point in social protection and are not being proposed here as a replacement for biomedical strategies, but indeed as a way to complement what we are doing and to enhance and strengthen our response to TB with the existing tools that we have today, in the hope that in about 15 years there will be some pharmaceutical company coming out with this magical product that will eliminate TB. I believe that there is a profound intersection between SDGs and TB elimination, and these intersections give us a tremendous political opportunity to expand the scope of our work, a political opportunity that is also a financial opportunity, because I think that there will be other source of money for us to do our work, and also a scientific opportunity to trying to enhance our response to TB by stimulating cross-sectoral collaborations and to have a better discussion with people that are probably dealing with a lot more TB patients that we know. I think this is probably the best way we have with the current tools that we have today in order to ensure TB elimination, or at least to improve the life of people living with TB. Thank you so much.